Medicine is a human service. I think our government is trying to do too much. Our health system is bigger than Germany's economy. It's 2.5 times the size of Russia's economy. 17 million people work in it. It's the size of a nation by itself. When I look at a hospital, I don't see technology, I see people.
Jeff, you're one of the US foremost health industry analysts who for 40 years analyzes changes in healthcare technology, financing, policy, and care organization. So there's a whole range of issues that I want to touch upon, but I really do want to thank you for spending time with me and our audience today talking about health systems, affordability of care, care administration, digital health, and other essential components of modern healthcare. To get started, Jeff, would you like to tell us a bit about your career and background?
Yeah, I mean, in brief, I entered the healthcare system in November of 1975. I worked in politics in our state of Illinois' governor's office and became an assistant to the dean of the medical school at the University of Chicago, a 700-bed inner-city teaching hospital in November of 1975. So we were the largest provider of care to a huge urban inner-city population on the south side of Chicago. And from there, I also taught in the business school at the University of Chicago for 11 or 12 years. I taught both health policy and I also taught, believe it or not, marketing for nonprofit institutions. So how do you adapt business principles to managing the care enterprise? From there, in the early 1980s, I affiliated with Ernst and Young, which had a very large consulting practice, and for most of the last 40 years have been in one way or another involved in consulting in healthcare for organizations across the healthcare system, not just hospitals, but physician groups, health plans, pharmaceutical and biotech firms. I've also invested extensively in startup and early stage healthcare companies on the leading edge of healthcare innovation. So that's a brief summary.
No two nations are alike when it comes to healthcare. In 2021, the Commonwealth Fund, assisted by the Organization for Economic Cooperation and Development and the World Health Organization, compared the healthcare system performance in 11 high-income countries, including Australia, Canada, the UK, France, Germany, etc., and the United States. They used indicators available across 5 domains: access to care, care process, administrative efficiency, equity, healthcare outcomes. And guess what? The US ranked 11th, meaning the last. While spending as a share of GDP has increased in all countries, spending growth in the US, by far the worst performer overall, has greatly exceeded the growth in the other 10 nations and constitutes 18%. To back up on that, in one of your speeches, you have compared healthcare systems in the US and Spain, with the latter one achieving way better health outcomes, spending a fifth as much. What's wrong with the US healthcare system in the recent years? And I don't want to say that maybe permanently wrong. Why is such a developed country finding itself at the bottom of the rankings and going behind in life expectancy, maternal and avoidable mortality, as well as facing a more significant disease burden?
It's a tough question, Sergey, but I think part of what is misleading and difficult about these analyses, and there are a whole bunch of inter-country comparisons that make the United States look bad, is how much of the problem can you attribute to our society and its political system, as opposed to the care system itself. Norway was the #1 ranked health system in the Commonwealth Fund comparisons. Norway has 5.3 million people, which is about the population of our city of Houston. We have 330 million people spread out over a vast area where there are huge differences in the society, in the economic circumstances of the people that live there and all the rest of it, and a health system that's supposed to take care of those 330 million people as a much tougher problem than the health system of a country like Norway or the Netherlands. Well, we're spending almost $4 trillion on healthcare in the United States. which is by itself the size of the GDP of Germany. And I think scale of enterprise is not our friend. It's not like you put in $4 trillion worth of wealth and you get health out the other end. Our health system is a part of a society that is broken and that needs fundamental changes, fundamental investments in its infrastructure and its people in order for it to do a good job. So I think, our U.S. health system is capable of doing a lot better than it is, but it needs some help from our political system in order to do that.
You've witnessed the amazing growth of national health expenditures from $700 billion back in 1990 to over $4 trillion in 2020. Is all the money spent with purpose? Which part of it is not?
It's really difficult to say. A few years ago, the consulting firm McKinsey did a remarkable intercountry analysis where it attempted to answer the question, what is it about that $4 trillion in spending that is different from the spending in other countries? And it wasn't the things that you expected. It wasn't administrative cost. It wasn't even the cost of drugs. The thing that really stood out in the comparisons were we use a lot less hospital care than most other countries, but we have this tremendous explosion of ambulatory care. And that ambulatory care is incredibly expensive compared to the ambulatory care in other countries. So, our health system is a very different beast than the health systems in most other places. It's much more decentralized. It's much more fragmented in where the money comes from and how it is used. And there is also a tremendous complexity associated with our multi-payer system that drives up the cost. So those are just a few of the things that I think make it difficult to get value for the $4 trillion.
How has the U.S. healthcare system changed over the previous 30 years? Has it ever been more accessible? How would you evaluate its efficiency? 30 or 40 years ago, hospitals were almost 40% of total healthcare spending. That number fell to about 30% by the early 1990s. And so nearly all of the growth in our healthcare infrastructure was in ambulatory services, in imaging, in surgery, in rehabilitation, in spreading out the emergency care system. So we have a much more diversified and complex infrastructure to deliver healthcare than most other countries do. When I travel abroad, people are astonished that almost 80% of the surgery in the United States is ambulatory. If you have a hip replacement today in the US, it's done on a same-day basis. You go home the same day. The vast majority of imaging studies are done in an outpatient or a non-hospital setting. So we have a ton of ambulatory infrastructure that does not exist in most of these other places. And some of that is clearly duplicative of the hospitals. Some of it is not efficiently used. So I think that's another piece of the puzzle. In 2020, the federal government healthcare spending is constituted 13.9% from total national health expenditures, seeing just a slight increase since 1990, whereas the states and local expenditures dropped from 16 to 14%. The government seems to be reluctant to spend more in public health care. Why is there such a disparity in private and public healthcare spendings despite the extensive debates that the latter should be increased?
Well, it's interesting. If you compare our per capita public sector effort to those of some of the other countries that outperform us, we're spending more than they are per capita on public health services. But it's simply the fact that we're not getting the results that we need from that amount of money. I think it's a very difficult problem. It isn't just a question of the amount of funding. It's the focus. It's the ability to get results for the money that I think has been the real challenge. There's no shortage of money in our healthcare system at $4 trillion. Our health system is bigger than Germany's economy. It's 2.5 times the size of Russia's economy. 17 million people work in it. It's the size of a nation by itself.
In Second Opinion, hosted by Senator Bill Frist, MD, you've interestingly spotted that ER is not going to solve the problem of undiagnosed and unmedicated hypertension. In 2020, nearly 30 million people in the US were uninsured and around 40 million Americans were underinsured. Back in 2019, 25% of the US population put off treatment for a serious medical condition because of its cost. From an economic perspective, delayed routine care, among other issues, eventually puts stress on emergency departments, which in the long run increases healthcare costs and ultimately burdens the federal budget, which seems to be a vicious circle here. How effectively is the issue of timely routine care being addressed on different levels of the US healthcare administration?
I think it is the case that we have grossly underinvested in primary and community-based services that could do a lot of those preventive things that you talked about. By the time someone gets to the emergency room, you're not going to be able to alter their trajectory, their health status. You're going to save their life. It is at the front end of that process where I think the real leverage is. We have an aging and overtaxed primary care infrastructure, and I think that building that infrastructure, replacing the older primary care physicians and other caregivers is going to be a big challenge for our country in the next 5 to 10 years.
Obamacare reform. Few words on that. Back in 2014, you were convinced that the Affordable Care Act was a deeply flawed bill and it hadn't done anything meaningful to reduce healthcare costs. If we reflect on 10 years, we see that the ACA's approval rating has grown from roughly 35% to 58% in October 2021. What does your personal approval rating currently look like?
I can tell you, I think part of the reason why Obamacare helped almost 30 million people get coverage. And it dropped the number of uninsured down into the low to middle single digits in many of our states. It did a tremendous amount of good, but it was so complicated. I mean, it was almost 1,000 pages of law. And I think the administration invested so much political energy in getting the bill passed that the moment they signed it into law, they just changed the topic. They began talking about other things instead of explaining to people how it was going to help them. So I think the administration really hurt itself by not explaining in English to the American public the things that their law was intended to do. And I think that had a very negative effect on the approval rating. But at the same time, you had a significant expansion in our Medicaid program, which is a program for caring for the poor. In almost 40 states in the country, you had a significant number of people that weren't eligible for Medicaid get coverage through private insurance. So, I mean, tens of millions of people were helped by Obamacare, and I think those individuals told their friends and neighbors that this was really a good thing, and I think that was ultimately what led to the rise in approval.
Right. So what's the 3 major amendments would you have made in this act?
I would have spent a lot less energy fiddling with incentives in the payment system. There was an explosion of technocratic ideas that if you changed the incentives to doctors and hospitals, that you get this miraculous improvement in care and in efficiency, and that simply hasn't happened. So I think a lot of energy in that area was misplaced. I also think that though efforts were made to strengthen public health and mental health services, in retrospect, those efforts were nowhere near vigorous enough. And we've seen a significant rise in the suicide rate. We've seen a significant rise in the number of people succumbing to drug overdoses. We could have seen this coming from a long way off and put resources into Obamacare to plug some of those gaps. Those are the big things, Sergey, that I would have changed with the 10 years of blinding hindsight.
How COVID-19 will be shaping the U.S. healthcare industry in the long-term perspective?
I think COVID-19 exposed fundamental gaps in our public health infrastructure, but also in the legitimacy of public health as a governmental function. We've grossly invested in public health compared to other countries, and I think COVID-19 revealed a lot of those gaps. We were unable to stand up an effective testing regime. We were unable to do the contact tracing that if you want to control an outbreak of infectious disease, you absolutely have to be able to do. We just didn't have the horsepower to do it. So I think I think COVID-19 revealed that the last 20 or 30 years, we really have stinted on public health investment, and we've allowed some of the crucial agencies, including federal agencies like the Center for Disease Control and Prevention, to kind of erode. And I think our ability to revitalize our public health sector and to restore the CDC to the position of international eminence and excellence that it enjoyed for many years is a very high priority post-COVID.
What input do the major businesses provide in the struggle to make healthcare more timely and accessible, especially in the time of the pandemic?
I can tell you that one of the unique features of our healthcare system is that almost half of the citizens of the United States are covered by employer-based plans. And so employers have a huge role to play in creating a health benefit that actually works for them. And, they've really struggled with this. When health costs rise rapidly, there is a intense focus on controlling the cost. When healthcare costs level off, as they have in the last 4 or 5 years, they turn their attention to something else. So if you ask the CEO of a large company, how important is the health benefit in your overall strategy, that varies from company to company, and there isn't a consistent leadership response.
Is there a lot of social responsibility around pertaining to my previous question?
I'm not sure I understand what you mean, Sergey.
I mean, is there a lot of responsibility? I mean, is there this essential responsibility that the companies, the businesses take in this struggle with coronavirus? I mean, in terms of how clearly they define their position, their attitude towards what's going on, and their willingness to invest in the struggle with the pandemic?
That's a really good question. Our businesses have been hammered by this pandemic. They've been hammered by what has been called the Great Resignation, where they lost a huge chunk of their most experienced workforce. They have struggled with huge drop-offs in utilization or patronage. Our entertainment industry and our travel industry are two examples of that. This pandemic has hammered our nation's businesses, and they've really been struggling to get back to a pre-pandemic state of normal. So I think, there's been almost a sense of emergency about getting these firms to be sustainable in light of COVID. And I think it's made it very difficult for them to look beyond it to, do we really need to make changes in how we pay for care, how we take care of our workforce? Are we doing an adequate job of protecting their families from problems like COVID? I think there's a lot of soul searching that's going to go on as this pandemic hopefully recedes.
It seems that the coronavirus pandemic has laid bare a fundamental flaw in the American healthcare system, which is nevertheless not receiving enough attention from public policy experts. In your opinion, would COVID-19 have been detected in the United States sooner, and would more people's lives have been saved if it had a centralized medical system?
That's a really great question. And I think part of the problem is when you get to the scale of American society of 330 million people, where do you locate the decision-making for responding to crises like COVID? And I think, what this crisis revealed is that we have way too much government and way too little focus of government power and authority for dealing with a problem like this. Our federal government was not prepared to deal with this. And we did not have the communication mechanisms in place to reach out into the communities where people are and to actually do the things that we needed to do to control this pandemic. I will say that the countries that did the most effective job of controlling this virus were islands. And a lot of what they did to control it was shut off travel into their countries. You think about, Taiwan, that was a great example. Japan. These countries shut down travel into their places and bought themselves time to mobilize their governments to deal effectively with this problem. By the time we shut down travel from Asia and Europe, COVID already had an enormous footprint, and we were already in deep trouble as a society, whether we realized it or not.
What are the areas where American healthcare has performed exceptionally well during the pandemic?
Well, I think there are two areas that really shone during this pandemic, and I wrote about one of them. Our nation's hospital systems were inundated in the first wave of COVID, and yet they were able to really act almost as public health entities and coordinate care across communities and regions, both to stand up testing and also to distribute the vaccines when they became available. So in many ways, the large hospital systems that we have in the United States substituted for a public health system that, as we suggested earlier, has really deteriorated around the edges. So that's one system that I think really outperformed. Our nation's hospital systems did an outstanding job of responding to this pandemic. But I think the other sector that has just blown us away has been our pharmaceutical companies. The idea that we could take a technology that had been thought of in principle, namely the mRNA vaccine technology, and apply it to this virus and stand up within a year, to be able to produce at scale vaccines that were specifically targeted at this virus was nothing short of miraculous. And I think we really need to give our pharmaceutical sector credit for mobilizing its energy. And for what it's worth, the Trump administration made a major contribution here with their Operation Warp Speed. They did a great job. So I think those two areas really outperformed and saved hundreds of thousands of lives, in my judgment, in the process.
Amazing, Jeff. Couldn't agree more. A whole range of studies over the last 2 decades have found that administrative expenses account for approximately 15 to probably 25% of total national health care expenditures in the US. Billing and coding costs, physician administrative activities, insurance administrative costs are the primary drivers of the expenses. Which of these are completely wasteful?
I think the fact that we have multiple payers in the United States does not excuse the fact that there ought to be a single information set required to validate medical necessity and to pay a bill. There's no reason on earth why every health insurance system should have its own set of data requirements, its own payment models, and all the rest of it. I think we made an effort in about 25 years ago with HIPAA, the Health Insurance Portability and Accountability Act, to try and standardize some of the administrative processes surrounding paying a bill, but it just didn't do the job. When you talk to physicians today and nurses, more than anything else, it is the documentation burden that these duplicative systems have imposed on them that is preventing them from doing their jobs. A typical physician or nurse is spending half their time typing, filling in forms that have as their sole purpose processing and justifying a medical bill. This is pure waste and could be eliminated with aggressive federal legislation to standardize payment data requirements and payment processes.
I think you've spotted it right. Getting back to HIPAA, I think it's not doing what it's originally meant for. I mean, it's mostly all about how you protect the healthcare information, how you implement the safeguards and everything. But originally, this is not where it was coming from. You agree to that?
Yeah, and I think, there was an administrative simplification agenda in HIPAA that anticipated that we were going to have an electronic payment system, that we were going to be moving from paper to electronic forms of both submitting and adjudicating bills. So there were efforts made in HIPAA to try and structure that frankly the insurance industry moved its way around. They didn't really comply with the spirit of HIPAA. And of course, in the Affordable Care Act in 2010, there was another, I would say in retrospect, half-hearted attempt to try and impose some order and to try and reduce the administrative burden, and it simply didn't have the effect intended. I believe this has reached the level of a crisis in our country. We have created a shortage of nurses and doctors by diverting so much of their time from the bedside, from the clinic, from the patient. We really need to address it in that post-COVID era as if it were a crisis, because it is a crisis.
looks like the US is not the only country that's facing the shortage of healthcare, like medical personnel. I mean, if you look around, pretty much the same thing is happening in the UK, in Germany. I'm just wondering where all these professionals leading to.
Well, I mean, I think part of it is that this is not an easy job, taking care of patients. It's an incredibly stressful and demanding job, and has become even more stressful during COVID. I mean, one of the tragedies of COVID is the increasing amount of abuse of caregivers that we're seeing in our hospitals and clinics, where patients are angry. They're angry because their lives have been changed by this pandemic, and they're taking it out on the caregivers. This has driven a lot of people to the point of saying, enough, no mas, I'm retiring, I'm going to do something else. So I think I think COVID has put stresses on healthcare systems all over the world because the people that they're taking care of are really struggling, and they've taken it out on the care system.
I really want to back you up on one important thing that you've mentioned. The structure of the US healthcare administration seems to be reflecting some specific societal values. A desire for choice gives rise to fragmentation of payers, which in return generates complexity in billing and expenses related to plan choice, such as marketing costs. Standardization of key administrative functions and improved IT capabilities can partially drive down the costs. What other mechanism can be effectively applied in order to address the excessive administrative expenses?
Well, I think that the two big things that have done it haven't been accommodating choice so much as the idea of the two main thrusts in health policy. On the conservative side of health policy, there's been this idea that if you provide people free healthcare, they will simply use it freely, and there will be a lot of waste and expense that results. On the progressive or liberal side, this idea that the health system is just this greedy octopus that sucks up resources, and so we need to impose all these administrative burdens to make sure that they don't render unnecessary care and simply line their pockets. And I think those two strains of health policy belief or ideology have led to parallel systems that have sucked resources out of the care system and devoted them to administration. We have had a festival of technocratic enthusiasm in our healthcare payment system in the United States that has generated a negative return to societal capital, that has damaged the care itself, and that has burned out our caregiving workforce. So I think we really need to disentangle ourselves from a lot of that technology and try to simplify payment transactions and documentation requirements. We can use technology to do this. I see a lot of things out there that are potentially useful in doing this in the IT world, but it is going to have to come from the policymakers themselves. They're going to have to back off from these two failed narratives in order to give our care system a chance to really do its job.
Would you go for a free healthcare for everyone? Would you vote for it, or would you rather prefer that we pay for our healthcare?
Well, one of our comedians, social commentators, P.J. O'Rourke once said that if you think care is expensive now, wait till it's free. I don't think free healthcare is really the issue. I think the issue is it is a societal function. Everybody needs to share a portion of the risk and responsibility for having that function be effective and efficient. If you absolve anybody of responsibility for it, you're going to end up with problems and with excessive cost. So to me, the real policy challenge and the complexity is how much risk should be borne by the hospitals, how much by the employer, how much by the caregiving system, how much by the caregivers, and how much by the patients. The idea that it's free to everybody is simply not a sustainable formula when you're starting with a $4 trillion base of spending.
Unfortunately, in my profession, I've seen cases when a nonprofit board seemed to be reluctant to implement advanced practices for the lack of motivation. At the same time, there are instances such as MSK Cancer Center who are actively investing in R&D, AI, telemedicine, patient safety. Are there any fundamental differences in this regard between public and private, for-profit and non-profit healthcare systems in the US from a patient standpoint, from a professional standpoint, how they implement changes, how they implement the advancements of new technologies?
So when you think about a complex healthcare enterprise, there are three pieces. There's governance, there is management and leadership, and then there is professional service. So to me, of those three things, the greatest variability in quality is on the governance side. There are nonprofit institutions in the United States that have exceptional governance, boards of trustees and community leadership. There are businesses that have exceptional boards of directors that are aggressively pushing management to deliver and to generate returns not only for shareholders but customers. And then there are organizations with spectacular professional cadres that are capable of working miracles. So getting all three of those things to work at the highest level is the challenge that these organizations face. And I think, again, of the three, governance is the weakest. Governance is the one where there's the most division of responsibility. And I don't think for profit, nonprofit, I really don't feel there's that much of a gradient in quality. But I do feel across those sectors that you identified that the gaps in governance are the ones that are the most difficult and that have the longest lasting, potentially negative effect on the organizations themselves.
I just wanted to get back to one of the advancements of healthcare, where the healthcare system performed well during the pandemic. One of those that you've mentioned previously, how fast the pharmaceutical companies responded to the pandemic, how fast they introduced new vaccines. How does that correlate to the fact that the large part of the population are very much reluctant about taking their shots and basically getting vaccinated?
I think in the United States in particular, but in also many other countries as well, you see this in many European countries, there is suspicion of institutions generally. There's suspicion of government, there's suspicion of business, there's suspicion of labor. So I think, a lot of this isn't specific to the science. It's that people are suspicious of institutions that they do not understand, that are doing things that are not obvious to them. And also, I think the internet has introduced this whole variable of flooding our society with misinformation and creating a framework where people are not getting the information that they need that enables them to make good decisions. So I think that's a great big piece of it.
I think people believe that most of the vaccines, if not all of them that have been released in the market, had not been properly tested. So they're still being tested just in a real world environment. And that's one of the reasons why they're not willing to take their shots. What do you think about that?
Well, there's got to be a happy medium between rushing out miracle drugs to solve a societal crisis and taking 10 or 15 years to approve a drug, which is the status quo ante. So there's got to be some happy medium in there. I mean, I really believe that there's a subset of people in the United States that believe that the vaccines were poisoning people. That isn't a function of the rapidity with which the vaccines were produced, but frankly, a paranoid media and internet milieu that is just flooding their brains with garbage. So I'm not sure that it's the approval process that was really the problem here, the rapidity with which things were approved, so much as the fact that there's just a tremendous amount of poisonous misinformation in our society, and it's very difficult for people to sort out what really to believe.
What's your definition of the quality of medical care?
Boy, is that a hard question to answer. I mean, I have been a major consumer of healthcare in the last 5 years. I had 5 major operations in 29 months. So after being a big expert on the health system for 40 years, I finally got to use it. And I can tell you that from my standpoint as a patient, it was the ability to feel trust in the people that were taking care of me and to believe that they had thought through the entire process that they were putting me through to the point where I felt confident I was going to be returned to my life in one piece. To me, that's my definition of quality. It ultimately stems from trust in the people that are taking care of me. And if I can trust them and trust that they will do the right thing and that they will treat me with dignity, to me, that's what quality means. I think trust in any part of our economy or society stems from the quality of the personal relationships that exist between people and the folks that are helping them. I don't think that the federal government, I don't think our state or local governments really have any influence at all on on that fundamental quality of the relationship. Medicine is a human service. And it's the humanity in those relationships that I think is the key to engendering and sustaining trust.
So what should be changed in the U.S. care process, meaning how you address the disease prevention, patient safety, care coordination, and patient engagement in order to achieve better care outcomes?
Again, a really difficult, complex question. I think we've got to decide as a society what we absolutely, at a minimum, need hospitals and physicians to do, to the information that they need to provide us in order for them to do their jobs. So I think we can define the boundaries around what it is that we want them to maximize in a way that we can measure it and hold them accountable for achieving it. But to get to that system, from a system where we have literally hundreds of core measures that we are asking people to submit information about and to judge them on the basis of, how do we get to a point where we make choices about the things that are the most important on the basis of which to judge them? You know, when I was attempting to pick the surgeons to replace my hips, I went out and tried to find the information I needed to do that. I couldn't do it. My orthopedic surgeon friends told me the two key things that I needed to find out, in addition to the cost, were what percentage of the surgeon's patients required re-operation to fix the prostheses, and what percentage of their patients had post-operative infections. I couldn't get that information anywhere. The physicians didn't know it. I couldn't find it online. So it seemed like, despite the fact that we're asking people to submit all this stuff, the crucial information that we need to make intelligent decisions about where to go to get our care and how to hold clinicians responsible, we couldn't get. So I'm not sure how to fix that, but I think our government is trying to do too much. And in the course of trying to do too much is imposing an excessive burden of time and documentation requirements on the people that are taking care of us.
I think most of the problems that you've mentioned are already being solved on the technology level. Again, back to the patient engagement, which is a very important part of the care process. I mean, if you take a preoperative or post-operative patient, and things you've mentioned, like unawareness of what happens next, like the lack of information, lack of understanding of the disease, its progression, the medications, and everything, is now being actively implemented by some technology companies investing in the patient engagement tools, various platforms, follow-up apps, and things like that. I don't know how much you've seen in your personal life or professional life. Is there many of these things that you see around? But I'm telling you that this is already happening, and I believe that this is the area that has seen some significant improvement, at least in the previous couple of years.
Well, Sergey, there's no question in my mind that there are a tremendous number of potentially useful tools out there, digital tools, to do these things. The problem is there are hundreds of thousands of them, and no way of really evaluating which ones work and which ones don't to enable me to make an intelligent choice of which ones I use. If you look between the Apple App Store and Google Play, there are between 325 and 350,000 healthcare-related apps that I can put on my phone here. How on earth do I sort out among all of those applications, the ones that work, the ones that actually are going to make a difference, that I want on this, to occupy a crucial piece of the screen real estate. There's no real way for me to do that. And I realize both the App Store and Google Play have consumer ratings. But the real question is, do they work? Are they scientifically valid? Do they actually make a difference? I have nowhere to go to get that information. And until that information is available, I think a lot of people are going to look at these tools sort of as this giant swarm of sandflies landing on them on the beach. They're just not going to have a basis for sorting out the ones they really want to use. And I think that's the biggest barrier right now, is just there's no reality test for a lot of these tools.
So Jeff, let's talk about investment in healthcare. According to Rock Health, the 2021 total funding among US-based digital health startups amounted to $29.1 billion, with overall investment nearly doubling the 2020's record of almost $15 billion. At the same time, we hear many voices using the word bubble. Do you think the potential for digital health investment is overestimated? How likely is that the growth trajectory will continue through the 5 coming years?
That 2020 number of 15 billion was double the 2019 number, which was 7.5. So, there has been a flood of money into this space. And I think I am one of the people that has used the term bubble. I think it is, it makes the .com era look a little bit like a high school pajama party by comparison. I think there is going to be a shaking out that takes place in digital health in the next 2 or 3 years. I think you're going to see large, powerful entities, including United Health Group's Optum, CVS, Aetna. I think you're going to see some of the large actors in our healthcare system beginning to consolidate some of the companies that have been funded in this space. And I think you're going to see a wave of efforts to create platforms that deliver multiple functions to populations of people. I think we're really going to see a period of consolidation here in the next 2 to 3 years. I don't think you're going to see the level of funding remain where it is.
It's already happening around. You've mentioned you had invested a lot in healthcare startups. Can you tell us a bit about that?
I began investing in early stage companies in the United States in the late 1980s. And after my book, Digital Medicine Implications for Healthcare Leaders, I focused a lot of my energy on digital health investing in the aughts, 2003, 2005, 2007. One of those companies has scaled and has grown to over $50 million a year. It is one of the earliest telehealth companies in the United States. They are the largest monitor of intensive care patients in the United States. The company is now called Hicuity Health. But a very recent investment that I've made in a company that I find really exciting is a small company called Health Tensor that is based in Los Angeles that directly addresses that problem of documentation and uses artificial intelligence and machine learning to try and dramatically reduce the amount of time that is required for a clinician to reach a diagnosis and to document it in the electronic health record. They've managed to cut all of the time requirements by using machine learning down to about 5 minutes to create a clinical note. So I've really enjoyed these relationships. A lot of the folks I'm investing with are much younger than me, but they do, and I think what they're looking for me is some, wisdom and guidance about how to scale and how to grow. And scaling and growth. Scaling and growth is the largest challenge.
You're still investing in healthcare?
Yeah, absolutely. And I'm 73 years old. So, I really, if I see an idea that really excites me, I'm going to write a check and I'm going to get in there and get my hands dirty and try and help it grow. So I am a believer in digital health. And I think there is a stage, you're willing to write a check, you really do believe in what you're doing.
Most people are familiar with the return of investment as something relating to the world of business rather than healthcare. How do you measure return of investment in healthcare? When does it come into play in the complicated system of hospitals, clinics, and public health centers? And what are the challenges of applying return of investment to healthcare?
Well, I think the problem is, Sergey, that there are so many intervening variables between, appropriating the money to pay for the Medicare program and healthy older people in the United States. There are so many intervening variables that I have trouble operationalizing the concept of return on investment. It seems to me that a healthcare system is a part of the infrastructure of a society, and it can't operate in isolation. One of the problems that we're having in the United States right now is that we have underinvested in mental health. And the result is that we are using our criminal justice system to deal with the problems of a lot of people that are having emotional problems and that are having mental health issues. So I think that it is very difficult to apply business principles to investing in something that's $4 trillion large. The real question is, do we have a just society that is enabling people to make contributions and to achieve their life goals and where the country takes better care of itself? I'm not sure ROI is really a very useful concept for looking at healthcare spending.
Jeff, I promise to keep it secret, but which field of healthcare do you consider the most attractive for investment?
Well, I'll tell you, I continue to feel that we are certainly our pharmaceutical and biotech sector there's nothing else like it in the world. And I continue to believe, regardless of some of the regulatory issues and concerns about the costs that we have here in the United States that are legitimate concerns, this is a remarkable sector and one that I think, has proven itself during this pandemic is capable of producing solutions quickly. We have a lot of opportunities in this space to do a better job and to help people all around the world. So I think of all of the sectors of our society right now, pharma and biotech are the ones that are really, from a medium to long term, the most attractive and most exciting sector.
Look, Germany is still using paperwork records, and e-prescription has not been widely adopted there. It actually was only introduced as recently as in 2020, while the level of population health is higher than in the US, with the country ranking 5th in the overall performance. It makes me think that the emergence of new technologies does not necessarily result in improved care outcomes. So what are the challenges of investing into the digital transformation of healthcare? What factors should you take into account?
Well, I think the example that you've raised is an excellent one, because Germany's health system is held up as one of the best models for how you finance care. It's privately financed but publicly regulated. There's been great sobriety in how government approaches healthcare spending, but there too, the ability of a government, whether it's a government of 90 million people or a government of 330 million people, to leverage investment in technology. And there's so many intervening variables that result in not using it in an optimum way. So I think we're going to look to many different countries of all different sizes for best practice as to how to take advantage of some of these digital tools and use them to improve care, to reduce the dropped batons, to improve coordination and continuity of care. I think we're going to need to be willing to learn from the countries that do the best job and to be fast followers and to copy what they're doing in an efficient and rapid way.
We have SpaceX and we have Blue Origin, but we don't seem to have a project of similar scale to address the issues of blindness or diabetes. My feeling is that businesses, venture funds, and billionaires would rather invest in the space industry, automotive, telecom, etc., rather than in healthcare. What's your opinion on that one?
Well, I'm not sure that's right. I mean, if you look at some of those billionaires, they have put money into longevity projects. Whether that's the right place to put the money or not is we could have an argument about that. But I think our tech billionaires are fascinated by the potential of our biotech industry to address some of the fundamental limitations on our care system. So I actually think that there is perhaps excessive optimism on the part of some of those folks about how easy these problems are to solve. I would say in general, our Silicon Valley folks grossly underestimate the complexity of medical problems, of illness in general. They tend to view it as a problem of data, of big data. It's really a problem of people and understanding the factors that affect those people that result in either damaging or improving their health. Medicine is a human service. It's the human part that makes it complicated and that's made it so hard to get right. And I think our tech sector has stubbed its toe over and over again because they have misunderstood the fundamental nature of human illness.
When you consider the benefits of digitalization in healthcare, there's a lot of potential for increasing process efficiency, for improving medical quality, as well as patient safety, driving down costs, and achieving sustainable economic success. There's a whole range of things we have covered in our conversation. So all the above factored in, what should be the primary purpose of introducing digital technologies in healthcare from your standpoint?
Well, I really believe that the idea that we have excessively relied on in-person interactions to manage our health. And I think the thing that excites me is the idea that digital tools can help promote continuous, low-intensity relationships between people and their caregivers in a way that it reduces the surprises, it reduces the potential for getting a drug wrong or having a bad drug reaction. I think there are so many ways in which digital technology can improve the care process by eliminating the drop batons, by improving communication. I mean, those are the areas that I think are most important. People that look on this, this device, that we all carry around with us, there's a computer chip in here, but what this really is a communications tool. And the areas where our health system has fallen down is in the communication between patients and the care system as a whole. That's the area where I'm most optimistic about digital technology, is that it can plug some of those holes, it can fill some of the gaps, it can produce better results, and it can give patients power to answer questions that maybe they had to rely on an in-person visit to get the answer to. So I just think I'm very optimistic about the future potential of digital technologies to improve our health system.
So would you say that communication is the area of health, of digital health, that needs investment more than others? Because there's a whole range of things, a whole range of gaps we have identified, like shortage of resources, the lack of basic trust, and the whole list of items that needs improvement. So which area of digital health needs investment more than others from the investor's standpoint?
Well, I mean, as we have suggested, until there's the equivalent of an app store that enables people to find, okay, I've got a problem with sleep, where's the best solution to that problem to be found? I think it is in the structure of the marketplace where the real barriers to using a lot of these tools is right now. But I also think there's a business model problem. I mean, a lot of those 300,000 apps on my phone are free, okay? But how does someone get paid to develop those applications and to perfect them and to make sure that they work properly? So I think one of the struggles, in addition to the fact that there's so many new ideas out there that are struggling to get recognition, is how do the people that build them get paid? And what is a responsible business model that enables us to grow the technologies that really do improve our health? I think that's the biggest barrier right now.
Jeff, what major changes in medical education and training do you foresee within the next 10 years? Do future physicians need to learn to understand analytics, algorithms, neural networks, and programming languages in order to be able to leverage these in their practice and keep up with the emerging technologies? Shall we see more IT in medical education?
Yes, I think it's going to be essential. But remember, what we're talking about here is we are educating digital natives who have grown up with using these tools. So, by the time someone gets to medical school, they're 24 or 25 years old. They have spent their entire lives in a digital environment where the digital part sort of disappears. It isn't viewed as something separate. And I think, where healthcare has really fallen back is, you look at the revolutionaries in this space, and I think particularly of Stephen Jobs here. What was Jobs' thing? He was fanatic about the user experience. He was fanatical about simplifying the use of his tools so that people could get the value out of it quickly without having to have a technical education. That drive to simplify and to improve the user experience has not yet begun in healthcare. And I think a lot of the young people that are entering this field that are digital natives look at the digital tools that they're being asked to use in the patient care process as just like they're like dinosaurs. It's like 20-year-old user interfaces, drop-down menus, incredible difficulty in finding information, terrible search tools. There's a ton of things that these digital natives are going to look at in our current digital infrastructure and go, my God, why are we relying on these antiquated tools when it's so easy for me to use the thing that's in my pocket? So I think our healthcare system has a long way to go in improving ease of use and in making the technology kind of disappear so that the patient and the doctor can simply communicate with one another and work together using digital tools to support the relationship.
Awesome. Jeff, I got the last one on the list of questions. Our previous speaker, famous US physician scientist Dr. Daniel Kraft, spoke about the likely shift from hospitals to hospitals, meaning at-home care with remote patient monitoring and telehealth support. In your Digital Medicine Implications for Healthcare Leaders book, published in 2003, you shared a panoramic view of information technology innovation in healthcare. So what's your current perspective of the evolution of healthcare?
Well, I agree with Dan Kraft about the idea that we can deliver a lot of complex care at home. But, I'm a little bit less gadget-centric than Dan is. We've had the potential to monitor and manage patients at home for the better part of 20 years, and yet haven't been able to use it. And again, that absence of a business model, I think, has really hurt us, is that how do you get paid to do it? But I think the other part where I differ from Dan a little bit is, when I look at a hospital, I don't see technology, I see people. And if you're going to move the hospital home, it's the caregiving part that's the really complicated part, not the technology. The technology to monitor patients remotely, to guide their care with digital tools has been there for 20 years, and we haven't been able to figure out how to use it. It's the ability to bring the caregivers into the home that's going to be the real problem. And I don't think that's going to be done by robots. It's too complicated. I know that because I've been a patient. It's going to be done by people. Just to reiterate a point I made earlier, medicine is a human service. It is the most complex thing we do in our economy. It's the human part that we've got to get right.
Jeff, that's all I got for you for today. Thank you for being with us. Your insights were so informative, and I'm sure it will be completely useful for our audience.
Sergey, thank you very much. It's been a lot of fun.